Haijing Hao with the University of Massachusetts will be your session moderator.
Good afternoon. Yeah, it's nice to see you, see the White Conference again. This is the third time I come to the White. And so this afternoon's the session, we will have three papers. And the first one is by Tianshu Sun from University of Maryland. The topic is motivating group donation, evidence from a large field experiment on blood donation.
All right. So thank you very much for having me. My name is Tianshu, and I'm a fifth-year PhD student at University of Maryland. Today, I'm going to present a joint work with Gordon Gao, who is here in the audience, and Ginger Jing from University of Maryland. The topic is motivating group donation, evidence from large field experiment on blood donation. The study is really about how public health agencies can leverage the social nature of human beings to incentivize behavioral change. Let me use the first few slides to explain the main idea. So previous studies has established that people behave differently when doing things in a group. We know we might have more drinks in group activities like a beer event. We may donate more in group events like a charity banquet. So in previous studies, researchers has, in general, created or assigned the group exogenously to cleanly identify the impact of group environment on the focal individuals. However, from the perspective of firms or public health agencies, it is interesting to understand how to motivate individuals to form a group in the first place. Only after that, we can take advantage of this positive group effect. So our research focused on this question, like how to motivate people to form a group. We specifically want to understand how blood banks can motivate donors to donate together. Our study connects two streams of literature. The first stream has found that people donate more in group environment either because of social image or altruism. The second stream of literature has investigated how social planners may motivate individual donors. So in this stream, group formation is irrelevant. Our study combined the two streams of research to study whether and how social planners can engage individual donors, but to motivate them to form a group. In this way, the social planner can take advantage both the intensive margin, which is the amount of blood donation, as well as the extensive margin, which is the number of donors. We believe motivating group donation can be especially effective in driving blood donation. So this is our context. So we think there are three reasons underlying this belief. First, it is in general much easier for existing donors to identify potential donors. Like they have kind of an information advantage over the blood bank. Second, it is much easier for existing donor to recruit their friends and family than the blood bank because blood donation is such a costly action. And finally, when donors donate with their friends, they are likely to donate more. So combining those three reasons, we believe motivating group donation can be effective in this context. And our study also answered a recent policy call by WHO. So as you can see, this is a map about global blood shortage. So the countries under red and orange are often under severe shortage. So WHO has called for a new approach to recruit blood donors to achieve both effectiveness and cost efficiency. So as you will see later in the study, we find the group donation indeed may outperform traditional approach like individual economic reward on both dimensions. So to test the effect of different treatments in driving group donation, we collaborate with one of the largest blood banks in China. The blood banks has 18 blood mobiles, fixed blood mobiles across the city, and has recruited more than 500,000 donations in the past 10 years. The blood bank can reach past donor, the majority of past donors using mobile messages, And in late 2014, we collaborated with the blood bank to run a 2-week campaign to reward donors with supermarket vouchers. And specifically, the reward is based on the amount of donation once donor came to the fixed blood mobile and choose the amount of donation. This is a high-stake experiment, so the maximum of reward, like 50 RMB, is about 8.5 US dollars, and equal to half-day wage of the citizens in the focal city. We draw 80,000 past donors from the database of the blood bank and randomly assign them into 7 test groups. So they will receive different messages. So the control group consists of 15,000 donors who would not receive any message. And on top of that, we test 2 types of interventions. The behavioral intervention, which is the first 2 columns, the reminder to donate, as well as the request to bring friends. The second type of interventions is economic reward, and we specifically try to test both the individual reward and group reward. For the interest of time, I'll focus my attention on discussing the difference between individual reward and group reward on the donation behavior. However, we also have some nuanced findings on the impact of behavioral intervention. So specifically, the individual reward here is stated as every donor who comes to donate will get a reward of 30 to 50 RMB. In contrast, we made the group reward conditional on group donation, which is stated as only if you come with a friend, each of you will get a reward of 30 to 50 RMB. And so with the experiment design, we implement it in later 2014 when we connect 3 types of outcomes. The donate, like for all those 80,000 donors in the experiment, we know like whether they have come to donate or not during this 2-week period. And we know like whether, if they come to donate, whether they bring friends or not. And finally, we can track the donation amount for both the focal donor as well as their friends. We further augment the data with rich archival data from the blood bank, including the donation history of all those 80,000 donors across the last 10 years, their demographics, and some preliminary health indicators. We also conduct surveys for all donors who come to donate. We try to measure their social environment. For instance, do you have friends who donate often in your social circle? Also, like, are you like willing to share your donation experience in the past with your friends? And also, we try to understand the coordination process. The survey can help us understand this kind of unobserved construct of the donors as well as the underlying group formation process. So with the rich data, we can both identify the impact of different interventions as well as understand the underlying mechanisms. So because of time constraint, I will highlight our empirical evidence in this one slide. So basically, the takeaway message is group reward works. And it works across all 3 margins. So the first margin, which is like whether you come to donate or not yourself, we find both individual reward and group reward increase donors' decision to donate. On the second margin, we find only group reward significantly increase like the probability for the donors to donate together. And finally, we find whenever people donate together, they donate a larger amount of blood. And combining all 3 margins, both the extensive margin and the intensive margin, we conclude that group rewards like works better. It leads to almost 100% increase in blood supply over the control group, and also about like 35% increase over the traditional individual economic reward. So I have all the tables and figures in the backup slides. So please feel free to discuss with me offline. But in the rest of this talk, I want to focus your attention on 2 questions. One is why group reward works better? What is the underlying mechanism? The second one is, can we go beyond the optimal policy at aggregate level and kind of within the experiment to identify like even better policy across this infinity dimensional policy space. So for the first question, we build an analytical model and find that group reward kind of works by motivating a different type of donors. And those donors who come under group reward are quite different from the donors who come under the individual reward. For the second question, we build a structural econometric model and use exogenous variation from the experiment to identify the individual level primitives. And then like with the structural model, we simulate different type of policy beyond those directly tested in the experiment. So that can help us kind of understand like, are there even better policy that we haven't tested? And the second thing for optimal policy is we drill into the heterogeneity. We use the rich individual level characteristics to identify optimal reward design at subgroup level. So let me use the last kind of 5 minutes to discuss the details of those two questions. So the first one is mechanism. So the intuition here is very straightforward. So we can characterize all donors across those two dimensions. One dimension is utility for kind of the vertical dimension is the utility for self-donation. So those people in red and in blue, like especially like in the top half plane, they have a positive utility in self-donation, which means like they're altruistic enough or like they have a very low cost for donation. Like for either reason, they have a positive utility at the end, so they will donate anyway. So those people in yellow, they have a negative self-donation utility, so they will never donate. So for the other dimension, the horizontal dimension, characterize utility to bring a friend on top of your self-donation. So those people on the right, like in blue part, they kind of have a positive social utility, either because of the social image or they think it's a very good chance to, it's a very good initiative to do with friends. So they are willing to bring friends kind of organically. So we can kind of divide the donors into all those three regions, the blue one, green one, and yellow one. So, and we can see the impact of individual reward and group reward in shifting the areas in the next two slides. So the first one is individual reward. So once we give individual reward to the donors, we kind of compensate those people who are on the margin of the self-donation axis. So you can see those people in the shadow and the green area, they would not donate without the reward, but they will be motivated to come because of an individual reward. So on the other hand, if we give the group reward, we're kind of compensating a different margin. We're motivating a different type of people. So those people in the shadow area and in blue, they will kind of be nudged from donate individually to kind of donate with their friends. So that's the basic mechanism of why group reward can work better. It kind of motivate a different type of donors and nudge them from individual donor to group donor. So we indeed find empirical evidence to support such mechanism. We find the treatment effect is much larger for donor who are married, local, and who are with more donations. Those are indicators of like small social cost. And also we find those donors who are motivated by the group donation are reported to much more likely to bring friends in the future. So the last 2 minutes I will spend on the structure model. So basically the idea here is we want to use the structure model to identify optimal reward design beyond those tested in the experiment. And we also want to explore the individual level heterogeneity. And some other benefits are we can compare the individual primitive with our survey, and also to conduct welfare analysis. So I think this is interesting because it can leverage both the benefit of fixed experiment approach, which is kind of creating the exogenous variation, with the benefit of structural model, which kind of help you extrapolate your prediction out of the sample. So I'll skip all the modeling part because time constraint, and just basically show you two graphs. And yeah, so this is the first graph. Like, this is the result from our structural model. Basically, if we find those two utility I just show you in a two-dimensional graph varies across different demographics. We find in general, both cost of donation and cost of bringing friends will decrease for like local people and for married people. And interestingly, it has a different implication for gender. So we find even though male donors has lower self-donation cost, in general, they have much higher cost of bringing friends. So this have different implication for the blood bank. They can target those married local female donors with group reward and target individual reward to the non-married, non-local, and male donors. And final slide, we also zoom in to each subgroup and simulate different policy beyond those tested in the experiment. We find group reward is indeed can do better on both cost dimension and supply dimension. And we can also achieve even better performance by combining individual reward and group reward. This is on the right bottom. And thank you very much. So this summary.
Yeah, now we have our discussant, Emilia from Johns Hopkins University.
Thank you. So before I start with the paper, I want to thank the organizers, Gordon, Jeff, and Ritu, for putting this conference together. There's always something to look forward to in October in DC, and it's been 6 years now, and I've been here at least 4 times. Every time it's great, and it's getting better. So thanks for inviting me. It's a pleasure to be here. And I have the pleasure to discuss this great paper, which is one of those papers where you gather to read the paper and you're like, okay, what do I say that's kind of intelligent? They said most of the things that can be said. And I did read the paper, so most of my comments are going to be on the paper. Tianshu did a great presentation, but I read a much more detailed version of this. So just a brief summary. The paper is about how to make endogenous group, how to use endogenous group formation to increase donations in a real-world setting. Most of the papers on group donations until now have used exogenous group formation. They're actually allowing the group formation to be endogenous, which is much more close to what happens in the real world. They reward group donors more than 4 times. When you bring a friend, so if you have a group, you have more than that intervention is more than 4 times cost effective than rewarding just individual donors. So use the group donor donation strategy. And they also have this very nice twist, which is that there are people who show up at the blood bank are heterogeneous. They have different characteristics, and they can tell who are the people who are most likely to donate and who are the people who are most likely to donate under different scenarios, so that the blood bank, there is a policy recommendation here. Who do you target if you want to get the biggest bang for the buck, basically, for blood donations? I really like the paper because the results are intuitively pleasing and they're consistent with the model. They have a structural model to actually describe their results and do counterfactuals. But I think most of us can agree that when we have a group of friends with us, we behave differently and more socially than when we are just by ourselves. I have a few suggestions about the write-up of the paper. I think you can take whichever ones you like. Might improve, your takeaway message from this. So, but first one, I was surprised that there are so few people donating, given the large outreach you guys have. So that's what I was joking with Gordon and Tianshu before the session. This is China, so 80,000 people is not a problem, right? So let's just find an experiment with 80,000 people. The difference between the control group and the group that brings the largest number of people to donate is only 30 extra people, even though we have such big numbers. And so the question I have is this cost effective? And it might be cost effective because you're basically just sending a text message. But if you have have some kind of comparison to experiments where they have paid people to donate, something that can give you some numbers on this, that would be a good addition to the paper, I think, because you can say, well, look, the numbers, there aren't that many people who are showing up, but it's still much better to do it this way than the other way. It would help to highlight how many additional people are enticed to participate. So it wasn't clear for me, are these people included, the extra friends that you bring, are they included in this table, or is this just the people who you treated? I assume it's the people who you treated, but then some of their friends donate as well. So I think you can highlight that even more. And that would be the intensive versus the extensive margin, right? If you know some things about these people. So are these people new donors, or are they donors who have donated before? And then, of course, you can even make an argument that says, well, okay, we have 50 new donors who have never donated before. Maybe they liked this experience. Maybe they felt good about themselves. Maybe they're going to come back. So you have like a long-term effect of this treatment. So you can think of it this way. You're bringing new people in, and maybe they're going to show up again. How many new donors do we get, and do they come back? I don't know. Maybe you have the data. Maybe you don't. I'm not going to ask you to get more data. You have a lot of data already. But I think that could, at least that was something I was wondering about. One thing that wasn't clear to me was what people get once they show up to donate, like all the gifts that they get. Does the nurse know which part of the experiment I am from? It appeared to me that all get the same gifts regardless of what they show up, which treatment group they're in. And so I thought that I must be wrong, because that means they may have potential effects for future campaigns. You know, I came up with 5 friends, and they still gave me the thing that they would have given me if I showed up by myself. So it wasn't clear in the paper. So I think you guys can do a better job clarifying this. And then the related thing is that they have a secondary treatment with different incentives to donate different amounts of blood, right? So the 30 to 50 RNB was how much you donate, right? So this is like another experiment that is imposed on top of the experiment that you're doing with bringing people over. So I wondered if there are some interaction effects that you can think about, because this is a separate intervention altogether. And then a bunch of things about there's a table where you show how much people donate. And the last thing I'm going to say is it would be interesting, and the modeling part of this, when you look at how much people donate in total as a group, is there some kind of a target, which is I show up by myself, I donate 300 milliliters, but I show up with 3 friends, each of us donate 100 milliliters. Is there some kind of argument to be made that people kind of have some idea how much they want to do? Does the group split it? Do they overdo it? Do they underdo it? How does it work in the different iterations of the treatment? And I thought this table could be a little more explicit about that, and maybe you can take it from there and add a couple of paragraphs on that. But overall, thanks for sending me the paper well in advance. It's a pleasure to read, and best of luck with it in the future. Thanks.
All right. Hello, everybody. My name is Brad Greenwood. I'm from Temple University. I was reflecting as kind of how White's grown, that this is actually the 3rd year in a row Ritu, Jeff, and Gordon have put me in the last session. So history is. What I hope you remember from this talk, we investigate how the entry of the rideshare platform Uber influences the rate of alcohol-related motor vehicle homicides. What we do is we juxtapose 2 services. First is the Uber Black service, which is a premium car service, and the second is Uber X, which is a lower-priced vehicle option. The results suggest limited to no effect of Uber Black entry on the number of alcohol-related motor vehicle homicides, but a significant and negative effect of Uber X. So when Uber X comes into a market, significant number of alcohol-related deaths are prevented. Further, we find limited effect during times of likely surge pricing. The back of the envelope math suggests that a full implementation of Uber across the country would translate to about 500 lives annually being saved and about $1.3 billion in annual public welfare. So for those of you who aren't familiar, or for those of you who did not download the app in order to get to the reception yesterday, despite your free service, what Uber and Lyft and Sidecar are a series of app-based ride-sharing services. And what you do is you sign into the platform, and it uses the GPS of your phone to determine where you are. Then you can solicit a car, and one will be sent to you, and they'll take you wherever you want to go, and then you're billed electronically, either through PayPal or a saved credit card that you have on the app or through Google Wallet. And the entry of these services has caused just an incredible amount of controversy. So in Philadelphia, which is where I am, they've been towing UberX drivers and impounding the cars. There have been accusations that Uber significantly threatens the safety of passengers. United has been accused of underhanded dealings to cut out taxi cabs at the airports that they fly into. But one of the questions that's been consistently asked is how these different ride-sharing services are affecting the number of DUIs, because they are giving drivers a new option for how to get home. And that's the question that we're going to ask today. What is the effect of entry of ride-sharing services on the rate of alcohol-related motor vehicle fatalities? And I'll describe why we use fatalities instead of just crashes as we go. Moreover, we're going to try and figure out by what mechanism this effect manifests. So, the logical question that first comes up is, why would an app influence drunk driving? And there's really two literatures that inform the question. The first is Exit Work and Platforms, following, Baucus and Bailey, Eric Brynjolfsson, some of the work by Jeff Parker and Marshall Van Alstyne. And the second is the criminology work in Rational Choice, so mostly Cornish and Clark. So why would an app influence? Platform theory would suggest basically two things: that platforms reduce market inefficiency by facilitating a buyer-seller match, and increasing information transparency in a market is going to reduce information asymmetries. The sum total of that is that if we increase the amount of locally available knowledge, we're going to expedite the exchange of goods and services. In the context of ride-sharing, we have essentially the exact same thing. What ride-sharing services do is reduce the information asymmetries between a patron and a driver. So if you think about what a taxi cab does, it does work on a platform, but it basically relies on stochastic discovery of the patron by the driver, because the driver has to drive around until they find somebody. What the app instead does is, by electronically soliciting the driver, it informs the driver that they're going to have a fare at a certain location, and informs the patron of exactly how long it's going to take the driver to get there, right? So if the utility, which is derived by the patron, by mitigating the search costs and reducing the uncertainty associated with discovering a driver, is significantly high, then they may be willing to pay a price premium as a result, which is our first hypothesis. H1, implementation of a premium car service will be associated with a negative and significant decrease in the rate of alcohol-related motor vehicle homicides. And I can tell Jeff McCullough is getting upset right now, because I'm offending his capitalist sensibilities. He's saying, why are people going to be willing to pay a premium? And he's absolutely right, because the first hypothesis resides on two assumptions. The first is that users are willing to pay the price of a cab in the first place, which is a tenuous assumption based on some of the literature. And the second is that the utility generated from mitigating uncertainty in search costs exceeds the price difference between a premium car service and the price of a taxi cab. And that's really not necessarily plausible. And rational choice theory offers some explanations why. Now, I know what you're thinking. I teach undergrads. The idea that drunks are rational can't possibly be true. But what rational choice theory suggests is that when presented with sufficient payouts and a limited marginal cost, rational individuals are more likely to engage in crimes. It isn't a result of individual level psychosis. And this is certainly true of drunks. Right? If we think about a taxi cab is certainly not costless. You have search costs plus the cost of the service, and it's not even guaranteed that you're going to get the service in the first place. I think most of us have been in the situation where we call a cab and they say they'll be there in 5 minutes, and 45 minutes later they still haven't arrived, right? So we have guaranteed costs on one side, and DUIs are not costless either. Usually cost about between $5,000 and $12,000 for a first DUI offense, but the probability of it being apprehended for driving under the influence is not 100%. So a reduction in the cost should shift the marginal probability of driving drunk, because the individual has guaranteed costs on one side and a marginal probability of accruing cost on the other. And that's our second hypothesis, is that implementation of a discount car service will be associated with a negative and significant decrease in the rate of alcohol-related motor vehicle homicides. So I'll offer one caveat before I dive into the empirics, is that H1 and H2 are certainly not mutually exclusive. We could have an effect for both premium car services and discount car services. It could be one or not the other, and really the goal of this investigation is to determine which one has a dominant effect. So how do we test this? The data that we use comes from the California Highway Patrol statewide integrated traffic reporting system. What it gives us is access to the number of crashes which occurred in each township and the blood alcohol content of the driver, i.e. if they're over 0.08 or not. The observation is going to be the town quarter, so within town J at time T, how many alcohol-related motor vehicle fatalities were there. We have 23 quarters in 540 townships in the state of California, which gives us about 12,420 observations. The data on Uber entry, so I'm going to use a dichotomous indicator of Uber entry for a lot of reasons, many of which are endogenous. So the number of drivers would be endogenous to the amount of service and the number of people who are around. So we're going to use a dichotomous entry variable, which is retrieved directly from the Uber blog when the Uber Black service came into an area and when the Uber X service came into the area. And if you look at the map of California, blue dots are Uber X entry, red dots are Uber Black entry. We have a fairly good coverage of most of California. The nice part about this setup is that the entry of Uber is both temporally and geographically dispersed, so we can apply a difference in difference estimation. So, as I say, much like a lot of the other folks that have been presenting over the last 2 days, we do a difference in difference OLS. The dependent variable is the log of the number of deaths plus 1 in YJT. The reason that we use the number of deaths, and this is really kind of the Achilles heel of this empirical investigation, is data availability. So there's a significant lag in the accrual of information which is not related to fatalities. So, and California is a little tepid about telling you when you have data and when you don't. And we're going to go through some robustness checks where we're trimming data off the end of the sample, try and make sure that we don't have an under-reporting bias. The independent variable is the dichotomous treatment, as I said, either Uber X or Uber Black. Controls are count and quarter fixed effects, allowing us to do difference in difference. And the standard errors are robust and clustered at the county level. So when we estimate this, we see a strong and significant negative effect of Uber X, but no effect of Uber Black. And this estimate indicates about a 3.7% decrease in the number of alcohol-related fatalities. Now, Ritu just gave me a look, which that look is, I don't believe you. So, continue. So there are a lot of problems with difference and differences, so, and we need to make sure that this result is robust. And the biggest one is that is the assumption of homogeneous time trends, so pre-treatment effects across treated and untreated locations. So the way that we test this is we use a relative time model, which has been discussed in a couple of different empiricals works. And what we do is we create a series of time dummies that indicate the relative distance between the current time period and when Uber eventually is implemented in a county. And we interact that with the dichotomous indicator, which says whether or not Uber ever enters the county. So what this, or ever enters the township. And what this allows us to do is visualize and estimate the pre-treatment and post-treatment effects so we can see the non-marginal, so the marginal effect in each time period after and before Uber enters. So if we look at it, what we see is both for Uber X and for Uber Black, we see an insignificant change in the level of, or in the rate of DUIs pre-treatment, right? So that indicates that the town fixed effects are really soaking up all that heterogeneity, and there's no difference in the trends. Interestingly, we see this strong effect that manifests about 9 to 12 months out afterwards for Uber X, saying that it takes about 9 to 12 months for the network to grow strong enough for Uber to have a negative and significant effect on the rate of alcohol-related motor vehicle fatalities. Strikingly, if we look at the Uber Black coefficients, no effect even in the long term begins to manifest. Right? So we can say with some amount of confidence that really the only effect that is manifesting is because of Uber X. All right, so into some robustness checks. We have a whole host of them. I'll kind of walk through them conceptually not to bore everybody with lots of numbers. So obviously the big concern here is exogenous entry, so randomly distributed factors might correlate with Uber entry. So we're going to throw in a whole mess of controls: population, median income, the number of college graduates, so who is likely to use the app, who is not likely to use the app, people who are living in poverty, people over the age of 65. We also control for the number of people working in law enforcement, as Uber is relatively controversial. And then we estimate both the difference in difference model and the relative time model, and the results remain consistent. The next concern is a specification error. So we do log the dependent variable, but despite being logged, it's not strictly Gaussian. So we replicate with non-transformed DV using both OLS and a QMLE Poisson. And quasi-maximum likelihood Poissons are wonderful. And you don't have to have the argument about whether a negative binomial or a Poisson is better. Just this one's better than both of them. And the results remain generally consistent. What else do we do? Other ride-sharing services. So it could be that Lyft and Sidecar and Cabulous, all of those firms are coming into the market as well. And which will bias the estimations because they roll out in very much the same pattern. So to remove the effect of other ride-sharing services, which don't give us quite the same difference in mechanism, we exclude all observations where Lyft, Sidecar, Flywheel, Curb are operating and re-estimate the models. The results remain consistent. Next concern we have is with appropriate counterfactuals. So Uber obviously comes into very, very large markets first. So it could be that Uber is coming into LA and San Francisco, and the appropriate counterfactual set, which right now we've defined as every other location in California, is not really a representative counterfactual. So we execute a coarse and exact match, where we match on the current period, the per capita income, so how wealthy a local area is, and the population of the city. Once again, the results remain consistent. They actually get quite a bit stronger. Final robustness checks, it really comes from Bertrand et al. There's this huge concern about serially correlated standard errors that emerge in difference models. We take 3 approaches, all of which pass: the random implementation model, which is Umerov's random implementation test, block bootstrap standard error, and finally a direct analysis of the correlation of the residuals. Once we see no serial correlation that emerges. So the results indicate no notable issues with the standard errors. General downward trend, so we look to see if the number of deaths if there is an overall decrease in the number of deaths which is not related to drunken driving. We find that the implementation of Uber does not correlate with sober deaths. Finally, the last one, as I said, is the data generating process. So there's a significant delay in the data accrual process for non-injury crashes. So we have to validate that the data accrual is not correlated with the independent variables of interest. So as long as it's not correlated, it shouldn't bias the estimates. So we remove the final year of data, replicate the estimations, and once again, the results remain consistent. Uber X has a significant and negative effect. Uber Black does not. So some empirical extensions. So the first question that we ask is surge pricing. Does the effect of Uber still manifest during spikes in demand? It could be plausible that the effect of Uber during spikes in demand intensifies or stays constant, which would suggest the lack of supply of taxis is what's driving this effect. Or if it attenuates during spikes in demand, it could suggest that cost is the driving mechanism. All right, so we recalculate our DV as the number of deaths during during high drinking holidays. So St. Patrick's Day, 4th of July, Super Bowl Sunday, as well as weekends where there's likely to be a spike in demand for the number of services, and replicate our estimations. And what we find actually is that the effect completely attenuates. So during periods of likely spikes in demand, where surge pricing will be put into effect, there's absolutely no effect on the alcohol-related motor vehicle homicide rate. Finally is the steady state demand question, where we try to see what the difference is between large and small cities. So it's plausible that it would have a larger effect in large cities because more Uber drivers would gravitate towards them. It could also be that it would be in smaller cities, right, which have fewer public transportation options. So we trichotomize the size of the city, and what we find is that there is a significant increase in the overall effect in large cities, to the extent that we actually have an effect of Uber Black in extremely large cities, so cities over 250,000 population, right? And that effect remains consistent in the fully specified model. So I am out of time, so I'll just keep going through. So in summary, the emergence of new business models poses significant problems for policymakers. What we find is that UberX significantly decreases the rate of alcohol-related motor vehicle fatalities. There's a limited effect of Uber Black, which manifests only in large cities, and a limited effect during periods of likely surge pricing. These effects take between 9 and 15 months to manifest. And economically, the results indicate that the entrance of UberX results in a 3.6 to 5.6 decrease in the rate of homicides. A complete implementation would create about $1.3 billion in public welfare and save about 500 lives annually. So thank you very much.
Our discussant is Michael from University of Maryland.
Okay, I was very pleased to read this paper. It's a very nice paper. I'm going to start out by giving a brief overview of the paper and then offer a few comments. So the question they're asking in this paper is, does Uber reduce the number of alcohol-related car deaths? There are two mechanisms. The first is a price effect, and the second is a supply effect. So they have some great data from the state of California, from Uber.com, and covariate data from the area health resource file. They run a diff and diff, and they also have a relative time model, what I call an event study model. And this is to assess if there is a different pre-trending. So the results suggest that UberX entry will reduce the rate of car deaths by 3.5 to 5.5%, and they did not find an effect for Uber Black. So this was a great paper. Had a good, strong question. They had lots of different tests of robustness. I thought the event study model was especially good. They had some good extensions, and overall, I thought it was a nicely executed paper. So the first comment I had is that in the paper, when you go through sort of what are the alternatives to drunk driving, I thought you could take a broader view. And you did mention in the talk that public transportation could be another, a different option. So I thought you could look to see if there are different effects by the size of the mass transit system. It could also be that you would see bigger effects when the transit system shut down for the day. So if you had time of day in the outcome data, I thought that could be a good little test to do. There could be other substitutes like drunk walking or drunk biking. So if you have a city that has good bike lanes, high density, you might find some different effects. If there was a weak part of the paper, I thought it came in this surge pricing model. And that's only because I really didn't fully get the logic of that model. It seemed to be that you're trying to test if it was a price effect or a supply effect, but it seemed to me that those two things are perfectly correlated. And so I wasn't sure if you did find an effect, what really would it suggest. And the other thing is, if you did have time of day in the outcome, you might be able to use a more sort of a more narrow bandwidth for such as a bar closing or end of the day. And my last comment was that even though you have 1 million extensions already, there was a couple more that I was curious about. The first is there any way to actually recover the price effect itself? So I thought if you could get variation in time and place in the relative price of UberX compared to a taxi, no. So I thought that might be the case, and so I thought, well, perhaps you could probably get that data today, right? And so you would just have geographic variation in price, and you could say, well, we think that difference should be constant over time. I'm not sure if that's true or not. And the last thing was that Uber should be crowding out some other service. So there should be some kind of income effect, and I wondered if that income effect would result in increase in alcohol consumption. And so I'm not sure if that would be welfare increasing or not, but that's something that you could think about. That's it. Thanks.
Our next presentation is a hidden Markov chain model of mental health dynamics of breast cancer patients using data from mHealth applications by Sanghee from Johns Hopkins University.
Yes, so hi everyone, I'm Sanghee from Johns Hopkins University. It is a great pleasure to present our work at this great workshop. This work is joint work with my colleagues at CHIDS and Assam Medical Center, which are South Korea. Our work is entitled A Hidden Markov Model of Mental Health Dynamics of Breast Cancer Patients using data from mHealth applications. So this work is at the very early stage, so I look forward to getting many comments and feedback on this work. And I found that this work is not very nicely fit to the session title, but I will claim that by detecting the pain and depression patients early, this work may contribute to reduce the number of depressed people and make our society a little happier. So before presenting our work, I'd like let me give you one question. So, how are you feeling today?
Great. Awesome.
Yes. Some of you may feel happy, and some of you may feel excited to learn about new study or meeting an old and new friend. But some of you may have bad feeling or may feel sad or depressed for some reason. And it is okay, and it is not a bad thing because those emotions are also the part of our daily lives. So this question is just a casual question, and it is frequently used to start a normal conversation. However, this particular question may have critical meaning for some people, especially those who are more susceptible to the depression. And depression is a common symptom within the severe disease treatment setting. For example, the breast cancer patient in our study. So early detection of depression is imperative because of its adverse impact on the patient treatment process and the healthcare outcome. However, when present, the mental distress is detected far less than 30% of the time in breast cancer patients. Then why the detection rate is so low? So why is it so difficult to detect depression among the breast cancer patients? The major difficulties comes mainly from the unique feature of mental disease. So mental disease have many unique features, and one of them is that mental disease is subjective disease. So it can be identified only through or based on the patient testimony. So it cannot be detected by the biological states like body temperature or the heartbeat rate or the blood pressure. So the time constraint for both patient and clinicians are among the biggest hurdle. And the next unique feature of the mental disease is that it is dynamic. And in particular, in our case, what makes it more difficult is that breast cancer patients usually experience unstable mental condition because of the side effect of their cancer treatment. Therefore, the traditional measure, which can be administered only during the patient visit to the hospital, cannot capture this dynamics of the mental condition of the individual patient. So the major challenges regarding the detection of depression is that data are collected very infrequently, and as a result, there are not sufficient number of observations, especially the time series data of each patient, for any meaningful statistical analysis. And it is extremely hard to capture the dynamics of individual patients. So in our study, what we did is that we analyzed over 11,000 daily mental health logs collected via a mobile health tracker from breast cancer patients during the 2-year span. So we have constructed a hidden Markov model Using our model, we probabilistically classify patients' mental status into three states: normal, moderate, and depressed, based on the observed daily mental logs. And each patient in each state exhibits significantly different log output. And we compared these results with the result from the traditional depression screening test result. And our analysis shows that the mental health logs collected through mobile applications can serve as quite a reliable indicator for detecting the patient's depression. So let me give you a little bit more detail of our study. So in the use of mobile health tracker application is expected to overcome the barriers that I discussed earlier, mainly the time constraint for both patient and clinicians. And in addition, it makes it much easier and convenient for patients to report their daily mental status through the mobile devices because of the high portability. So the patient can report their daily mood without the restriction of time and space. So it allows to collect data at a much higher frequency, and the short interval of data collection actually have two significant positive results. One is that it definitely obviously increased the number of observations, which potentially unveil the dynamics of the mental condition. And the second point is that because it collected daily, it reduces potential measurement errors by making it much easier for patients to recall their true mental status. Yeah. However, there are concerns for the use of the mobile data for the clinical setting because obviously it uses much simpler questions than the traditional measures. It only used in our case, we use only three very, very simple questions. But in the traditional setting, the questionnaires at least contains 9 questions, which address different aspects of the depression. So some people, there are some critics on whether it is really valid to be used for the clinical purpose. And the data are collected by the patient without the assistance from home. So the validity of data itself is quite questionable. There has been some studies on the mobile health trackers, but most studies focused on managerial suggestions and technical guidelines. And there were empirical studies are only few, and most of the empirical studies focused on the evaluation of the feasibility of data collection. So there has been no study which evaluate the validity of the use of data. Also, there has been no attempt, to the best of our knowledge, there has been no attempts to model the dynamics of mental condition of the patient using the data collected from mobile devices. So we collected the data using an application which is called PIRAPAT. So it collects PRO of breast cancer patient. So this app is developed by the team. It is not a commercial app, and this app was developed by the team at the medical center with which one of our co-authors is affiliated. And this app was distributed to the breast cancer patient who were receiving the treatment from that medical center, and consented to use the application. So we asked 3 very, very simple questions. So one is, how would you rate the quality of your sleep last night? So basically sleep quality and your mood and the anxiety level on each day. So and the data are collected from South Korea, and we collected these daily logs from 78 breast cancer patients. Even though the number of patients who participated in this study is not huge, but we could collect pretty good number of data from those patients. So we collected over more than 11,000 observations during the 2-year span from April 2013 to March 2015, and it translates that we have on average 143 observations per patient, ranging from 1 to 498. And apart from the log data from the mobile application, we also collected the screening result from the traditional depression screening test, which is PHQ-9 test. And this is the most widely used depression screening test tool in the primary care setting. And the test is administered in paper form, and it is administered at most once in 2 weeks. And basically, it measures the number of days the patient have symptoms related to depression over the 2 weeks period. So the patient have to recall what they felt over the last 2 weeks and record the number of days related to the symptom. So the scores of PHQ-9 ranges between 0 and 27, and a patient whose score is over 5 is considered being depressed. So our initial approach was running a simple logic regression. So we examined the association between the daily logs with the traditional depression screening test result, which is PHQ-9 score, and we ran the logic panel regression with the dependent variable indicating whether the patient's PHQ-9 score is over 5 or not. And this result shows that the daily logs have sufficient information to tell about the patient's depression status. However, because we had to aggregate the data in a biweekly format to create the panel that matches the structure of the PHQ-9 scores. So we lost the information a lot, and mainly the data and the information about the daily dynamics. So we changed our approach, and we decided to adopt a hidden Markov model. So HMM models a stochastic process of hidden, unobserved state with a set of observations that are also produced through another set of stochastic process. So in our case, we consider a patient reside in one unobserved mental state, and we label that 1 as a normal state and N as a severely depressed. Then, for example, the patient I may reside in the state 1 at time t, which is normal, and at time t plus 1, his status may stay at the same state or move to the other state like moderate or depressed or severely depressed and so on. And this process followed the Markov process, and this is modeled as a state transition probability. And our observed sequence is the daily logs, and as I mentioned, we collect sleep, mood, and anxiety. And we assume that this follows a multivariate normal distribution. And the last component of hidden Markov model is initial state probability, and we defined it as a stationary probability of the state transition probability following the conventional approach. So joint likelihood of observing the sequence of daily logs given the model parameter set is given as this, and we estimated the model parameters using the expectation maximization algorithm. So here's the result. So we identified 3 mental status: normal, moderate, and depressed. And the graph on the right-hand side shows that the patient in each state shows a significantly different log output. So the figure on the top shows the log output of normal patient, and the second is moderate and the depressed. And this is the state transition matrix. And so, for example, the patient whose state was normal at time t, the probability that that person will stay at the same state, which is normal, is 94%. And with a 5% chance, his state can move to moderate, and with a 0.3%, his probability can move to the depressed. So all states are very sticky, meaning that the patient relatively stays in the same state with a high probability. However, this transition still produce sufficient dynamics among the patient's mental health condition, which I will show in later. And we recovered the patient's most likely mental status given the observed log, and we compared again this result with the PHQ-9 scores. And this is the accuracy rate is 67%, and the AUC of the ROC curve is 0.7. And these numbers may not sound like so impressive. However, considering that this model was developed only using the log data and independent from the PHQ-9 scores, we believe that these results are quite impressive. And after observing the differences between the result from 2 approaches, we found that the differences are not necessarily bad news. So in this graph, it shows the transition, an example of the state transition of a patient over time, and the black line shows the state transition identified by our HMM model, and the red line shows the PHQ-9 scores. And we could see similar patterns in many other patients, and it reveals that the traditional measure sometimes failed to capture the dynamics which were identified by our HMM model. So I will skip the implications because I already mentioned it in several times, but as I mentioned, because this is a very early stage, so we acknowledge that there are many limitations in our study. And first of all, among them, the biggest critical limitation is that our current model does not fully address the individual heterogeneity. So we plan to extend our model to incorporate the individual heterogeneity in the transition matrix so that each individual patient can exhibit the different dynamics. And we plan to extend our model to incorporate potential covariate which can affect the patient's depression. Thank you.
My name is Haijing Hao. I'm from UMass Boston. It's very happy to discuss this paper. I had a little experience with HMM model, but I hope it can contribute. So first, we review the study. So this is a mobile mental health trackers for depression in breast cancer among the breast cancer patients. I think that's very interesting and very exciting an application because I don't know others. Like when I was sick, I really don't want to turn on computer, look at the internet, but I still check my phone, check the mobile and the apps. I think it's very convenient for patients. And also for the depression problem, surely should be sometimes the daily changing, so very dynamic. Okay, so back to this study. So they say they implement a study from the largest hospital in South Korea, and the application called Peter Pat. And they have, just now she had showed us, and they count the 3 wearable, sleep satisfaction, mood, and anxiety, and from 0 to 10 or 0 to 7. They all from the smaller the number, the better the situation. And they collect more than 10,000 mental health logs, like clicks from the patient. But I have a question a little, is like, so that seems that you have about 143 records per patient, if on average, but so that's almost over 2 years. I'm wondering, this is maybe a little small number. That means that some patients may not check this every day, even not every other day. Okay, yeah, it's pretty good. This is the average number. Some patients may check fewer times. So I'm a little concerned about this, how much dynamic can represent the patient's mood. And then they also have a PHQ-9. This is like a traditional clinical questionnaire to detect a patient's depression status. About the hidden Markov chain model, I think that's a very good choice to choose a hidden Markov chain model, because if we only use the traditional questionnaire, there are kind of only two answers, yes or no, right? But for hidden Markov chain model, they figure out there's a moderate status for patients. I think that's quite normal. Usually we don't just want to say, the patients are depressed or not. Probably there's some status in between. So I think this is one of the advantages to choose hidden Markov chain model. Particularly hidden Markov chain model said we don't observe the status directly. If we can see a person from the face, we can see, oh, he's or she is depressed. No, that's not practical. So hidden Markov chain model is trying to help us to figure out some unobservable state, but it can be the other variables can disclose, uncover that state. And so for their result, they do find 3 status, and also these 3 status quite sticky. And so that's another question I may ask. Like, if this is very sticky, so that means if this patient is normal, he had a very few probabilities, very small chance to become moderate or become depressed. Then, what's the purpose to use a Markov model? Markov model, we care about the transition probability. We really want to look at something they translate. If they don't translate, that's this is my question. I don't have a better solution or suggestion I can give. I just wonder, if also, is this true? They are so sticky. People is in moderate state. Will very small probability to become depressed? Or is this because your data is not big enough, right? If you could have a patient, maybe you cannot mandate, ask them to check their state every day. But if you over 2 years, some patients you only have 100 clicks or 100 records, that's too few. That's maybe the problem. You could not figure out the transition probability. And so that's just my comments along this. Surely the contribution very nice. This is one of the first study provide empirical evidence, like daily those daily mental health logs can be used for detecting the mental distress. And also, HMM model, the theoretical understanding for the mental health dynamics. And this is also very convenient for patients to use. Discussion, just now I already talk about this. Another things like I hope you can emphasize more to use mobile trackers than the traditional questionnaire, and how to why select HMM model. Surely, just now the author also mentioned they should add heterogeneity to the model, because every people is different. The last I may say, if you want to try the developmental trajectory analysis, that may be interesting to follow how people change over time. Okay, so that's all my comments.
Brad, you mentioned that during the, you could observe that when there is a surge in prices of UberX, the observed effects reduces. And did you say that?
So it's so Uber is really tight-lipped about data, really. So they won't share anything. So that's during times of likely surge pricing. So during times that we know that there's a spike in DUIs, so nights and weekends, and drinking holidays. So things like 4th of July.
How could you observe that? Because you mentioned that your time periods were quarters.
So we have more granular data. We just collapse the DV into the number of deaths that occurred at those times. We use the time quarter, or so the town quarter, basically to increase the interpretability of the results. So we have more specific time on when the death occurred, specific by hour.
You also mentioned that, but again, could you clarify, how could you know that the effect that you're observing is not because of Lyft, it's because of UberX?
Well, so we do eliminate the other ride-sharing services. So we take all of the town quarters where Lyft or Cabulous or Curb are operating, and we just rip them right out of the regression. So because there's huge multicollinearity problems if we start controlling for them, so we just expel all of them from the regressions and replicate it.
Thank you.
So with respect to the last paper, there are several problems. Okay, first of all, you have very small data, so many of the methods you use will not work statistically because you cannot prove any confidence. Second, why did you use EM? Because for the model you have, we can do actually exact computation. Third, in the output probabilities you have, the variables are not continuous, right? You're measuring sleep, mood, and something else, anxiety. You have basically discrete variables, so how can you justify Gaussian models? Did you check Gaussian models, or you just did Gaussian models because you can compute? So there are many problems, and because of these problems in approximations, as the reviewer mentioned, I don't have confidence that the results you got are statistically verifiable.
Yeah, first of all, I agree that the sample size may be considered as small because we considered only 78 breast cancer patients. So it may be hard. It will be difficult to generalize this results to the patient in the other setting or the other hospital or the other medical center. So we will think about that. And the third point is that the sleep and our variables are measured as a numeric value, which range from 0 to 7, and we assume that those variables follow a multivariate normal distribution.
But you can test that and see if it is true or false, right? So the model is in the right direction, but I think you need a lot more to do, increasing data, testing the outcomes, and then see if indeed the states are sticky. Because if the states are sticky, then as the reviewer mentioned, then the utility of such a model goes down. The last suggestion I want to make is that we want to make people happy, right? Even if they're depressed. So it would be interesting to add to the hidden model perhaps an intervention variable, so you can actually test whether by taking a sequence of steps, you can actually move them from one state to the other. That would be a very good thing to do. So I will encourage you to consider extending that in that direction.
Thank you for the comments. And we are working with the developer of the app, so we plan to include some interventions in the app, next version of the application. Thank you.
All right, thanks again to the panel.